I'm Kelly Tran, a pharmacy student from Texas Tech University Health Science Center. Today we're going to be talking about metformin use in treating childhood obesity. Today's objectives are to learn about the prevalence of childhood obesity, define childhood obesity and understand the risks that it can lead to, identify the typical treatment for treating childhood obesity, and assessing the use of metformin in the treatment plan. In the U.S., prevalence of obesity for children and adolescents aged 2 to 19 was determined to be about 18.5%. There's about 13.7 million children and adolescents currently having obesity. The prevalence increases as the age increases, such as when they're 2 to 5, they're 13.9%, whereas 6 to 11 is 18.4%, and 12 to 19 is 20.6%. Child obesity is more common among certain populations, such as the Hispanic, compared to the non-Hispanic Black or white children. Socioeconomic has also an impact on the prevalence of obesity. Obesity prevalence was 18.9% among children and adolescents aged 2 to 19 years in the lowest income group, 19.9% among those in the middle income groups, and 10.9% among those in the highest income group. The prevalence of obesity decreased with increasing level of education of the household head among children and adolescents. Childhood obesity can be determined by the measurement of body mass index. Overweight is defined as BMI at or above the 85th percentile and below the 95th percentile for children and teens of the same age and sex, and obesity is defined as a BMI at or above the 95th percentile for children and teens of the same age and sex. CDC growth chart shown up here is normally used to compare the BMI of a child to other children of that same age and sex to figure out what percentile they fall into. So why do we care about if a child is overweight or obese? There are health risks that is correlated with obesity, and that is problems that we should be concerned for. Obesity during childhood can harm the body in a variety of ways, and children who have obesity are more likely to have hypertension and hyperlipidemia, which is a risk factor for cardiovascular diseases. They have increased risk of impaired glucose tolerance, insulin resistance, and type 2 diabetes. They have risks such as respiratory problems such as asthma and sleep apnea. They can have joint problem and musculoskeletal discomfort. Childhood obesity is also related to psychological problems such as anxiety and depression. They can lead to lower self-esteem and can lead to bullying and stigma. We have concern for children who are obese are more likely to become adults with obesity, which lead to increased risk of heart disease, type 2 diabetes, and cancer. The typical treatment for childhood obesity is lifestyle modification, diet and healthy eating, meaning they should have decreased consumption of fast food or consumption of table sugar, any sugar sweetened beverages, any high fructose corn syrup. They want to increase the consumption of whole food rather than fruit juices. They should also decrease the consumption of high fat, high sodium, or processed food. Want to ensure that there's proper portion control, making sure that the child is having adequate intake of dietary fiber, fruits, and vegetables. You want to make sure that they have timely, regular meals and avoid having the constant snacking throughout the days, especially between supper. Exercise and physical activity is also very important. You want to have a minimum of 20 minutes of moderate to vigorous physical activity, with the goal being able to do 60 minutes per day. You want to encourage and support the child to limit the non-academic screen time to only 1 to 2 hours per day and decrease their other sedentary behavior, such as watching TV or just laying down. So what is the role of metformin in treating pediatric obesity? Metformin is FDA approved for children greater than 10 years with type 2 diabetes. It is often used off-label as used for weight loss in children. The only FDA approved medication for childhood obesity is orlistat and liraglutide, which is only approved in children 12 years and older. Or children can also do phentermine when they're 16 and older. The belief to how metformin promotes weight loss is the reduction of hepatic glucose production, the decrease in intestinal glucose absorption, increased peripheral insulin sensitivity, and the possibility of reduction in appetite by raising the glucagon-like peptide 1 levels. And metformin has a reasonably safety profile with only GI side effects, which can be minimized by slowly increasing the dosage. The benefit of metformin is examined in the systemic review. Efficacy and safety of metformin for obesity, a systemic review by Maswar R. Brunetti V. and a little s. The study was conducted due to there being several randomized controlled trials conducted in children that reveals promising short-term results regarding weight loss and homeostatic model assessment of insulin resistance level with metformin compared with a placebo and lifestyle intervention. However, other studies have revealed that there was no benefits due to these inconsistency between the results between multiple trials, and that these individual studies have small numbers of participants and variable follow-up duration. They decided a systemic review should be conducted. The objective was to assess the efficacy and safety of metformin with lifestyle intervention compared with a placebo with lifestyle intervention in children and adolescents with obesity, focusing on the BMI, insulin resistance, and GI adverse effects. The study selected about 24 randomized controlled trials. Out of the 24, they had 16 studies that had the mean change from baseline or the adverse effects were reported. The study concluded that the effects of metformin was modestly efficacious at decreasing the BMI. The insulin resistance did decrease in the metformin treatment arm. However, the metformin treatment arm was associated with a higher report rate of adverse GI effects. The clinical significance and long-term effects of these beneficial effects are unknown due to the way the study was conducted. There was uncertainty in benefits to varying results from studies, such as out of the 16, 14 of the study shows that the effects of metformin did decrease BMI versus with 2 showed there was an increase in BMI. So where does metformin stand in treating pediatric obesity? First and foremost, the first-line treatment for childhood obesity should be lifestyle modification, changing the diet, making sure they are eating healthily, making sure they are being active in exercise and physical activities, and then we should consider adding on metformin if that lifestyle modification is not enough, or to continue keeping that weight loss as an adjunctive treatment. since metformin does have some benefits such as its modest efficacy, availability, cost, and how it's relatively safe with just GI side effects, which can be minimized by a slowly increase in dose.